Okay, now I would like to discuss about some pathology regarding uterus, like there may be prolapse, there may be a fibroid, there may be endometriosis. First of all, start with this pelvic organ prolapse. First of all, I would like to discuss about POP, pelvic organ prolapse. Pelvic organ prolapse can be in anterior, like bladder, it may be cystosol, in posterior, like rectum, like rectocele, and the entire small intestine can mm, come out through the vagina, and it can cause enterocele. There may be procedentia, complete prolapse, and there may be apical prolapse, like uterus and vaginal valve. Why it happens, why the prolapse happens? It may be due to obesity, it may be due to multiparity, grand multi, one of the cause. It may be due to hysterectomy, and the postmenopausal. So these are the four causes of having pregnant pelvic organ prolapse. Now, what are the clinical presentation? Pelvic pressure, obstructed voiding, urinary retention. If there is anterior anterior uh, is there is an anterior prolapse, like bladder, like cystosol, there may be obstructive voiding, there may be urinary retention, urinary incontinence. If there is posterior prolapse, posterior involvement, there may be constipation, fecal urgency, continence, and some sort of sexual dysfunction happens. Management is weight loss, pelvic floor exercise, like Kegel exercise, and you can be their vaginal pressure can be used, and surgical repair. Okay, patients with severe prolonged prolapse can develop vaginal or cervical erosion. Cervical erosion. Patient with severe prolonged prolapse can develop vaginal or cervical erosion. If the cervix and the vaginal apex protrudes through the introitus and rub on clothing, and become inflamed and denuded. So, patients with severe prolonged prolapse can develop vaginal or cervical erosion. Prolonged prolapse can cause vaginal because it can rub on clothing, it can protrude through the introitus and become inflamed and denuded. Those erosion can cause AUB, abnormal uterine bleeding. Postcoital postmenopausal treatment of prolapse via pressure and surgical correction. Erosion can be treated with vaginal estrogen. Erosion can be treated with vaginal estrogen. Erosion can be treated with vaginal estrogen. What is the most what is the recommended treatment for an elderly patient with severe pelvic organ prolapse? It colpoclasis, that means closure of the vagina, used for elderly women who are not surgical candidates. So closure of the vagina, who uh, colpoclasis, closure of the vagina, used in elderly women which are not good surgical candidate and no longer sexually active. Colpoclasis can be performed without general anesthesia. So this can be used without general anesthesia because older female, elderly female may have some cardiac problem, and there may be problem in reversibility if you give anesthesia. So it can be done without anesthesia. This is the fibroid. This is uterine fibroid. It may be pedunculated, it may be intracavitary, it may be intramural. This is within the muscle intramural. This is subserosal. This is submucosal, and this one is subserosal. It is diagnosed via ultrasonography. And this is one prolapsed uterine fibroid. The prolapsed uterine fibroid. This fibroid is prolapsed. Prolapsed. Okay. So symptomatic submucosal fibroid who desire for future are treated with hysteroscopic mammectomy. So symptomatic submucosal fibroid who desire for future fertility. Symptomatic submucosal fibroid who desire for future fertility, go for hysterectomic mammectomy. What type of fibroid are associated with heavy menstrual bleeding and recurrent pregnancy loss? Submucosal fibroid. Submucosal and intracavitary fibroid leiomyomata. These are the common cause of submucosal and intracavitary fibroid can cause heavy menstrual bleeding and recurrent pregnancy loss. Whatever fibroids are associated with bulk symptoms like irregular uterine enlargement, subserosal and pedunculated fibroid leiomyomata, subserosal and pedunculated fibroid. So mucosal goes with recurrent pregnancy loss. Mucosal goes with recurrent pregnancy loss if there is irregular uterine enlargement, subserosal pedunculated fibroid. It can cause bulk symptoms like constipation, incomplete voiding, and pelvic pressure. So serosal pedunculated. What is the most likely diagnosis in a woman with labor pain despite recently having her period? Women with the labor pain recently having her period, pelvic examination show irregularly enlarged uterus, dilated cervix, and firm with a firm mass visible through the internal mass. It is prolapsing uterine fibroid. It's a prolapse. So, so labor pain, despite recently having her looks like labor pain recently having her period. Pelvic examination show an irregularly enlarged uterus and dilated cervix with a firm visible through the external loss, that is a prolapse uterine fibroid. Typically occur in submucosal or intracavitary. Submucosal or intracavitary can cause recurrent pregnancy loss. Submucosal or intracavitary fibroid prolapse through the cervical os, resulting in labor pain and cervical dilation. Uterine sarcoma is indistinguishable from fibroid. Uterine sarcoma is distinguishable from fibroid because it should be suspected in postmenopausal women. It should be suspected in postmenopausal women, usually solitary mass with necrosis and hemorrhage. What type of what medical therapy may be used in short-term treatment of symptomatic fiber refractory to OCP and NSAIDs? GnRH agonists like leuprolide. Whatever medical therapy should be used in short-term management of symptomatic fibroid, short-term management, go for GnRH agonists because they are refractory to OCP and NSAID, not recommended for more than 3 to 6 months because typically used before hysterectomy or to bridge a woman close to menopause or to bridge woman close to menopause. So it is used as a bridging therapy of menopause and it is used before a hysterectomy. Leiomyoma uteri can outgrow their blood supply, degenerate during pregnancy, and because myometrial blood flow shifts towards a developing fetus and placenta. An infarcted degenerating uterine fibroid can cause severe abdominal pain, uterine tenderness, and a palpable firm tender mass, and the signs of inflammation like leukocytosis. A high sensitive test is used for evaluation of the submucosal fibroid. A highly sensitive test like submucosal fibroid is sonohysterography, a form of transvaginal ultrasonography that infuses saline into the uterine cavity for improved detection of intrauterine pathology like fibroid. Or so sonohysterography it is a form of TVS. It is a form of sonohysterography. It is a form of transvaginal sonography that infuses saline into the uterine cavity for improved detection of intrauterine pathology like fibroid and polyp. Now endometriosis is ectopic implantation of the endometrial gland. Ectopic gland. There may be a dysmenorrhea, dyspareunia, dysphagia, dysuria, and these are all the menstruation. And one eye infertility. Physical examination show eye for removable uterus, cervical motion tenderness, adnexal mass, and rectovaginal septum, posterior cul-de-sac, and uterosacral ligament nodule. Diagnosis, direct visualization, and surgical biopsy. Direct visualization, surgical biopsy, and medication. OCP, surgical resection to the 3Ds. There may be 5D, you can say dysmenorrhea, dyspareunia, dysphagia, dysuria, and disorder of menstruation along with eye infertility. Okay, this is the management of the endometriosis. Yeah, suspected endometriosis, there will be chronic pelvic pain, dysmenorrhea, dyspareunia, dysphagia, contraindication for medical therapy. For definitive diagnosis, history of infertility, and concern for malignancy or adnexal mass, yes, laparoscopy, no, NSAID or contraceptive should be done. So, management of the endometriosis, contraindication to the medical therapy, definitive need for definitive diagnosis, if there is any history of infertility, if there is concern for malignancy or adnexal mass, then if these are the features, then you should go for laparoscopy. If they are not the cause, then go for NSAID without OCPs. What recommended management for asymptomatic patient incidentally discovered endometriosis during unrelated surgery during an unrelated surgery? Observation. Intraoperative findings may include adhesion, powder brown lesion, and or chocolate cyst. Asymptomatic patients do not require any treatment. What is the definitive treatment? Definitive treatment: endometriosis, hysterectomy, or oophorectomy. Hysterectomy and oophorectomy typically done in symptomatic women who have completed their childbearing. What is the diagnosis? What is the likely diagnosis in a young woman with chronic pelvic pain, especially with exercise, and a homogeneous cystic ovarian mass on ultrasound ovarian endometrioma? So, chronic pelvic pain, especially with exercise, chronic pelvic pain, especially with exercise, and homogeneous cystic ovarian mass on ultrasound. It is ovarian endometrioma, secondary or endometriosis. Patient with uterine or pelvic sidewall implants and have chronic pain with exercise intercourse like dyspareunia, as well as it can cause tubal infertility. It can cause tubal infertility. This is ovary. This is unilocular hypoechoic ovarian mass. This is endometriosis. Uterus endometrium. Homogeneous hypoechoic ovum. Homogeneous hypoechoic ovarian cyst and a ground glass appearance Okay. Now okay. Now I will go for the five question at a row. Okay, 38-year-old woman, gravida 3, barrel 1, abortive 1, admitted to the hospital at 33 weeks of gestation because of suspected pyelonephritis as evidenced by temperature and back pain, as evidenced by temperature and the back pain. She has a costovertebral angle tenderness for 10 days. She has costovertebral angle tenderness for 10 days. And there are costovertebral angle tenderness for 10 days and mild contraction for 4 hours. IV ampicillin therapy is started. Urine analysis is consistent with the urinary tract infection. The fetal heart rate pattern is shown. Which of the following is the most likely explanation of this pattern? Urinalysis consistent with urinary tract infection. A fetal heart rate is shown. Which of the following is most likely explanation for this pattern? So, suspected pyelonephritis evidence by high temperature back pain, IV ampicillin, 33 weeks of pregnancy, costovertebral angle tenderness, urine analysis, UTI. Which of the thing might happen? So there is tachycardia, maternal fever can cause tachycardia. So fetal heart rate is high, tachycardia due to maternal fever as far I know. Okay, 62-year-old woman comes to the physician because of 2 episodes of vaginal bleeding during the past 3 weeks. Menopause occurred 12 years ago. She has hypertension treated with AC inhibitor and a type 2 diabetes mellitus treated with oral hypoglycemic agent. She has no abnormal annual pap smear. She is 163 centimeter, 5 feet 4 inch. BMI is 25. Pelvic examination show a normal cervix and the uterus with blood at the cervical os. A 6 into 8 ovarian mass is palpated. A 6 into 8 left ovarian mass is palpated. Pelvic ultrasound confirms the results of the physical examination. An endometrial biopsy is shown. An endometrial biopsy specimen shows atypical complex hyperplasia. Atypical complex hyperplasia and ovarian mass is suspected. And which of the following is the most likely diagnosis? It may be uh, ovarian mass. So ovarian carcinoma most likely. Okay, now 28-year-old woman, gravida 1 para 1, has been anemic and has had hot flashes for the past 6 months. She takes thyroid medication, chronic lymphocytic thyroid Hashimoto. After using OCP for 2 years, she discontinued taking it 3 years ago. She got discontinued taking it 3 years. FSH is 62, estradiol low, thyroid stimulating hormone normal, prolactin normal, low FSH. FSH high, um, it's not hypothalamic dysfunction. It it's not post pill amenorrhea. I think it's a hypothalamic dysfunction. August 25. 35-year-old woman, gravida 2, para 2, chronic hypertension, has spontaneous onset of labor for 39 weeks of gestation. A 4 hours of regular contraction and second stage 5 months. She spontaneously deliver 3.6 kg newborn, new epidural anesthesia approximately 2 minutes after separation of the placenta. She develops apnea, cyanosis, severe hypertension during the unsuccessful resuscitation. The patient develops during unsuccessful resuscitation, patient develop bleeding from the vagina and venipuncture site. I think it's septicemia, septic shock. Okay, that's it. Okay, this is autonomic ovarian failure. This one is granulosa cell tumor, not the ovarian carcinoma. I'm going. This is a fever, maternal fever. That's why there is fetal tachycardia. So if we go for the explanation, so maternal fever can cause tachycardia. defined as fetal heart rate greater than 160. Causes fetal tachycardia include hypoxia, fetal anemia. So maternal fever can cause this tachycardia. Okay, granulosa cell tumor, vaginal bleeding in postmenopausal women. Why it is not ovarian carcinoma? First, ovarian carcinoma or ovarian fibroma may present with palpable adnexal mass. However, neither of these entitles the secret estrogen are unlikely to lead to atypical endometrial hyperplasia. So, endometrial biopsy show atypical complex hyperplasia. So, ovarian carcinoma or ovarian fibroma secret estrogen, but unlikely to lead to atypical endometrial hyperplasia. Vaginal bleeding and postmenopausal women should raise suspicion for malignancy, include a uterine or ovarian carcinoma, ovarian, sex choristomal tumors, or a group of neoplasm which may secrete sex hormones. Include estrogen or testosterone granulosa cell tumor are the most common sex choristomal tumor and present with adnexal mass with an evidence of estrogen excess and such as breast tenderness, uterine bleeding. Estrogen excess is known as the risk factor of estrogen excess is the known of risk factor of atypical endometrial hyperplasia and endometrial carcinoma. In this case, granulosa cell tumor ultrasonography may show a reveal large complex ovarian mass which may contain septation or cyst. Histologic diagnosis is made by biopsy, indication of call legs in the body leading to pathology. Granulosa cell tumor is treated with surgical resection. So in here there is normal cervix, uterus is filled with blood, 8 centimeter ovarian mass palpated, pelvic ultrasonography, confirmed physical examination, and endometrial biopsy shows atypical complex hyperplasia. It shows atypical complex hyperplasia. Which of the following is the most likely diagnosis? So endometrial biopsy specimen shows atypical complex hyperplasia, and that is granulosa cell tumor. Its maternal fever. Autonomic ovarian failure is known as primary ovarian insufficiency. In primary ovarian insufficiency, FSH is high. It is characterized by autoimmune inflammation and destruction of the ovaries, leading to decreased estrogen production, diminished follicle reserve, loss of ovarian stromal cells. Follicle stimulating hormone and LH are appropriately increased because of lack of feedback from estrogen on the anterior pituitary. Seen in this case, it is most often idiopathic, and it is more common in women with karyotype abnormality or other autoimmune disease such as chronic lymphocytic thyroiditis. So this is autonomic ovarian failure. So autonomic ovarian failure or primary ovarian insufficiency, reproductive age and ovulation, amenorrhea, infertility, ovulation results in decreased estrogen, increased FSH, LH, decreased estrogen, increased FSH, LH. It is commonly associated with other autoimmune disorder or karyotype abnormality. The last one is amniotic fluid aspiration. I thought it's septic shock. It's why it is amniotic fluid. Embolism is rare, potentially fatal complication of the childbirth caused by amniotic fluid entering the maternal circulation. It most commonly occurs during delivery or in the immediate postpartum period. It presents with acute onset apnea, cyanosis, circulatory collapse leading to altered mental status or unconsciousness. It is further associated with diffuse bleeding from venipuncture site in the or the vagina. A caesarean delivery incision due to DIC signs of fetal distress can also occur if the fetus remains in the utero at the time occurrence. Vital signs will disclose tachycardia, hypoxemia, severe hypertension. The patient can quickly decompensate into cardiovascular collapse and cardiopulmonary arrest. Treatment is generally supportive with patients often requiring fluids and blood products and mechanical ventilation. The maternal and infant mortality rate, the maternal and infant mortality rate is high. Okay, that's it. That's